Let's look at the mechanism of action of Agomelatine, the trade name Valdoxan. Agomelatine is a melatonergic agonist. It activates M1 and M2 receptors. We know that melatonin plays an important role in sleep. It's part of the circadian rhythm. So when sunlight strikes the retinal cells, the communication to the suprachiasmatic nucleus, and the stopping of melatonin release, with the release of melatonin around dusk when sun goes down, and then the allowance into sleep. So one of the properties of agomelatine is to promote slow wave sleep. It has mild sedative properties, but because it does not have antihistaminergic activity, one doesn't tend to feel groggy during the morning. When you compare that to mirtazapine, mirtazapine tends to have some cases that sedation or grogginess that patients complain of. Similarly, it does not have antihistaminergic blockade, and therefore weight gain is not a side effect. Mirtazapine has that particular side effect. The second property of agomelatine is a 5-HT2C antagonism. 5-HT2C antagonism is linked to sexual function. So one of the advantages of blocking that particular receptor is that agomelatine is not associated with sexual dysfunction. In fact, it can be used as a treatment for antidepressant-induced sexual dysfunction. Now, interestingly, the combination of these two increases dopamine and noradrenaline in the prefrontal cortex without increase of dopamine or noradrenaline in the mesolimbic system. And the advantage of that is that it does not necessarily activate the mesolimbic system and hence can be used in bipolar depression as well. Now, if you're a clinician, you would love the Academy. We cover this more in the Academy by Psych-Scene. If you want to delve deeper into structured psychiatry learning, head to the Academy where we have loads of videos, PDF structured courses to take your learning to the next level. Think better, think smarter, discover more, and change lives. Agomelatine is evidence-based in the treatment of bipolar depression, of course, in combination with mood stabilizers. Generally, antidepressants should not be used unopposed in bipolar depression. To summarize, agomelatine is an agonist at M1, M2, promoting slow wave sleep, has sedative effects, and also is a 5-HT2C antagonist, thereby promoting dopamine and noradrenaline in the prefrontal cortex, and this has beneficial effects in the treatment of depression, improving the cognitive symptomatology and also preventing or treating the anhedonia. It can be used in SSRI-induced sexual dysfunction, SSRI-induced emotional blunting, and is an effective augmentation strategy at the milder end of the spectrum of melancholic depression. Because agomelatine does not have serotonergic potentiation, it can be used successfully with SSRIs or SNRIs as an augmentation strategy. The main side effect of agomelatine is one has to monitor liver function tests, usually at 3, 6, 12, and 24 weeks. If the dose goes up to the maximum, which is 50 milligrams, then liver function tests again need to be monitored at the same frequency, 3, 6, 12, and 24 weeks. Agomelatine is metabolized by the CYP1A2 enzyme. Therefore, if one is using an inducer or an inhibitor, one has to make some dose adjustments. Agomelatine is also evidence-based with recent evidence now of benefits in anxiety disorders. There are case reports of benefits in OCD and also ADHD at the very mild end of the spectrum. But it's not surprising because, as we saw, it increases dopamine in the prefrontal cortex, and in clinical practice, sometimes adding agomelatine when patients complain of anhedonia or amotivation or cognitive deficits can give you a test as to whether the dopaminergic hypothesis is predominant, and therefore one can then consider which dopaminergic or noradrenergic agents one needs to consider to get maximal benefit. So in terms of a hierarchy, one can consider agomelatine at the lower end of the spectrum of the dopaminergic and noradrenergic antidepressants. The higher ones include, say, mirtazapine, higher dose, bupropion, R-modafinil, and modafinil. Interestingly, R-modafinil and modafinil are actually lower DAT and NAT inhibitors compared to bupropion. So one would put them lower. However, many of the regulatory authorities consider them as psychostimulants. And then at the highest level, of course, we know we're dealing with stimulants such as dexamphetamine and methylphenidate.